I guess let's dig into the, the quality of life aspect a little bit more for patients. Certainly keeping patients feeling as well as possible for as long as possible is really our goal with metastatic disease, right? That's what we're all aiming for. The thought of switching these patients earlier, there is a question of, keeping them feeling well, keeping them symptom-free from progression, of course. But then additionally, the data show that patients on Camizestrant really felt well. Side effects were all grade 1, grade 2 for the most part. So tell us a little bit more about kind of how you would think about that as far as sequencing and, when someone is coming off of progressing on that first line therapy and sort of side effect management and I don't know, what would make this more appealing for you to reach for potentially?
I think broadly speaking, when we think about drugs that are going to help patients, we want drugs that are going to help patients live longer or live better with improved quality of life. And importantly, this trial did show improvement in quality of life with this early switching strategy. I think there are a couple of factors that are important in that. One is how well is the drug tolerated? If we were switching early to perhaps a chemotherapy or an antibody drug conjugate, that may cause more toxicity from the actual drug. And then, as you pointed out, there's also the consideration of preventing symptoms related to disease. And that's, of course, a significant concern in our patients, whether it's bone pain, shortness of breath, or other symptoms. We want to do everything we can to maintain patients feeling quite well for as long as possible.
Okay, so let's talk a little bit about, dig in a little bit deeper, I guess, on why intervening early could potentially be helpful. I know, again, as we touched on at the very beginning, there have been sort of different takes on the data and the study design. Certainly, understandably, I think there are a lot of things that are still immature, right? Overall survival, things like that I think we don't have the full story yet, but I think for you in practice, I think thinking about sort of this early intervention strategy, how would you implement that? And I guess even now, how are you sort of going about doing, molecular testing, and at what time points? In the study, their patients were checked every 2 to 3 months. Is this something that you would sort of coincide with scans, or kind of talk me through how you would think about that clinically in your practice?
All very important questions. I think there's, the intricacies of a clinical trial design and also how to implement something into clinical practice. And sometimes those two can be a little bit different. I would say in general, I've been a big proponent of liquid biopsy and ctDNA and how that can impact clinical care in the metastatic setting. I think one of the considerations or potential challenges is the frequency of ctDNA testing. And in the trial, the specific focus, of course, was the ESR1 resistance mutation. But you can imagine in clinical practice, when ordering ctDNA, it is likely that we'd be getting broader panels with more and more mutations. So I think one of the questions I have is, if we're doing this serial monitoring and we see development of different mutations, some clonal evolution that's not ESR1, how do we handle that? What does that mean? And I think those questions still need to be answered.
Yeah, I think that's a great point. Another thing that I've thought about along the same lines is, if you're monitoring that and someone does happen to show, we know not all progression is created equal. I think we all think about maybe a tiny bit of progression in the bone differently than we do other types of radiologic progression.